Thank you very much for having me here today. I'm excited to speak about the value of global palliative care, and I'll specifically be focused on low and middle income countries, or LMICs. I'll speak on the value of palliative care to patients and families with incurable disease, but also to health systems, ultimately making the argument for the role of palliative care as a poverty reduction strategy globally. My name is Eleanor Reid. I'm an assistant professor of emergency medicine and global health at Yale University in the United States. So let's get started. I'd like to use this roadmap for today's talk, understanding that the topic is vast, complex, and I have 20 minutes. So I have tried to include everything that is critical, but could not include everything I wished. So this is in no ways exhaustive, but really meant as an introduction to the topic for those who are interested. So we'll start with just some definitions. What is palliative care? I'll introduce this global access divide or abyss, and then we'll highlight what is known and where there are gaps. In the next section, I'll talk through how research is addressing these gaps in knowledge, and we'll focus on 3 systematic reviews, sort of providing the 10,000-foot view, and then we'll take a closer look on the ground with 1 study from Malawi and some work in Ethiopia. I'll offer some final conclusions and then talk with you about what's on the horizon in this exciting field. First, what is palliative care? I think there's some confusion here. I often hear people using the term hospice care for palliative care. So hospice care really is just at the very end of life, whereas palliative care ideally is started at the time of diagnosis with incurable disease. So I'd like to direct your attention to this bow tie model. This was developed by the World Health Organization. This infographic really depicts the relationship between disease management, curative care, and palliative care. And so if we start on the left of the screen, at the time of initial diagnosis, disease management, that wedge of the pie, essentially that green triangle you see there, is quite large. As treatment options wane, you see palliative care taking on a larger role, an expanding role. Up to bereavement, and then survivor care for those survivors, the family members. The next really important thing I think to understand is that palliative care is patient-centered care. Right, so this is a diagram from the New England Journal of Medicine Catalyst that I've borrowed. And palliative care is it's patient-centered, family-centered, holistic care. And what I like about this infographic is the 360 degrees of circles around this patient. And I think the most important takeaways here are that this is bidirectional. Care is guided by healthcare providers in concert with patients and families, completely aligning with patient wishes. It's focused on not only physical and emotional well-being, symptom management, really what matters most to patients and families, and transparency. So that, in a nutshell, is palliative care. And so now we'll go into a little bit of the health economics of palliative care. So for context, I'm sure many in the audience are aware. So NCDs, non-communicable disease, they're rising globally, but especially in low and middle income countries, for example, cancer diagnoses. At the same time, we have late disease presentations because of a lack of screening programs. So patients present far later in their disease course, often with advanced, even incurable disease at the time of diagnosis. So those are important points to understand. The other important point is this concept of out-of-pocket payments. Within fragile health systems, there isn't always financial protection the way we have in higher income countries with health insurance schemes. Out-of-pocket payments are cash payments at point of service for medications, hospitalizations, equipment like syringes, IV fluids, tubing, that type of thing. And so as a result, this combination of factors, from the late presentations to out-of-pocket payments, and we see that serious illness often leads to what we call catastrophic health expenditures, and medical impoverishment, families that become impoverished because of a medical diagnosis. And so I've borrowed this infographic from my colleague, Dr. Bates, and we'll hear about her work in Malawi in just a couple of slides. But what I like about this diagram is that it shows where palliative care breaks that cycle of poverty. And so at sort of 3 o'clock on this on this wheel, you can see late diagnosis of a life-limiting illness. And here that red X marks palliative care. So palliative care blocks those high levels of catastrophic costs, often provides an improved function, even an ability to return to work. But if you follow along on the blue, so the cycle would have been high levels of catastrophic costs, reduced household income, reduced household capability and well-being, leading to lower levels of education and training. And you can see how this cycle repeats. And so this is really getting to the crux of the matter, right? With palliative care as a potential poverty reduction strategy, as you can see based on this infographic. Unfortunately, there's limited access to palliative care where it's needed most, and that's in low and middle income countries. On this next slide, we're going to talk about the global access divide in palliative care, which mirrors the opiate access divide. And I challenge you to try to find Africa on this map. So this is a map, a world map in which countries are either swollen or shrunk relative to the amount of opiate medications prescribed per death from cancer or HIV and AIDS. And I think this is really a dramatic representation of the lack of palliative care in Africa. However, that doesn't mean there's no palliative care, quite the opposite. And I want to take a moment to acknowledge some of the resources that are out there and the tireless supporters of palliative care on the continent of Africa. I don't have time or scope in this presentation to go through all of them, but on a continent-wide basis, these are 2 organizations looking at improving access to palliative care in Africa. And then I think you'll find on a country-to-country basis, there are also other resources. I am most familiar with Ethiopia, which is where my work is focused, and so that is my bias, and that's why I've included what is available in Ethiopia, this nonprofit called Hospice Ethiopia, and a website about Ethiopian palliative care. So just because on this map Africa is tiny doesn't mean there aren't people who are working hard to improve things there. So let me now take a moment to talk about what we know and where the gaps are. So we know that palliative care is essential. The World Health Organization has said as much, and under universal health coverage, both access to palliative care and reducing financial risks with seeking care are critical. We know that palliative care works. It reduces pain and burdensome symptoms as well as psychosocial distress. We know that it aligns with patient wishes. It's patient-centered care. It promotes a good death. We also know about the access abyss. That was the map we just referred to. In high-income countries, there's very strong evidence that palliative care is cost-effective on a health system level and also on sort of a microfinance on a patient level. So what's missing? We're missing hard health economic data from low and middle income countries that will really support health decision makers in low and middle income countries, helping them to allocate funds for integrated public palliative care services. There's also some gaps in education. Palliative care is traditionally part of undergraduate medical education. Patients aren't commonly aware of palliative care. The gaps in opiate and access to opiates and other analgesics, this is really on a country-to-country basis. And then there's also a gap, maybe a barrier is a better term for this, but in delivering bad news and in the communication piece, where truly, it's a very it's a difficult thing. It's a skill to deliver bad news, to be transparent about a diagnosis, and this is even harder in some cultures than in others. And so that is another challenge facing palliative care providers in many LMIC settings. So these are the gaps. And now I'd like to talk about how research in this area is addressing these gaps. The first thing we'll do is take a look at the sort of 10,000-foot view with 3 systematic reviews. So systematic reviews are helpful when individual sort of data is sparse and you're trying to summarize the literature, summarize what is known on this topic. And so these are 3 systematic reviews. There are others. These are just the 3 I've chosen to highlight, all of which have been published in the last 3 or 4 years, so quite recent. The first one is one that I worked on with some fantastic collaborators, looking specifically at those out-of-pocket costs that we mentioned earlier. And we wanted to get a better understanding of out-of-pocket costs as drivers for medical impoverishment. So we screened over 9,000 manuscripts and included 12 in our final review. Not surprisingly, we found that as illness advances and with disease severity, out-of-pocket costs are increased, right? There are more cash payments at point of service, the sicker you are. And that most of those cash payments were for medications and hospitalizations. A high percentage of the populations in all of these 12 studies reported financial catastrophe, lost income, and having to pull their children out of school because they couldn't afford it to pay for care. The next systematic review is from 2018. And here my colleagues and I looked specifically at what is known about the cost effectiveness of palliative care in low and middle income countries. So here we screened over 750 manuscripts and included 10 in our final analysis. We did find that there was quite a bit of heterogeneity between the studies and specifically between what was measured. There was variable quality, the health economic, especially of the health economic data. However, despite all of that, we did find that there were multiple examples of low-cost palliative care delivery strategies in low and middle income countries. Patient-reported outcomes were favorable, and that palliative care was less costly than the alternative. This last review that I'll include is very, I think, has really very powerful results. So this was a review of reviews. So these researchers looked at 43 different reviews on this topic and really found that home-based palliative care offers substantial savings to health systems through decreasing total healthcare costs, resource use, while improving patient and caregiver outcomes. So that's all. That's exciting. All of those findings. And now what we'll do is go sort of to a ground level and take a look on 2 projects that were done in Africa, one in Malawi, and this is Dr. Bates's work. This just came out in the Lancet Global Health, and it's just a fantastic effort and a fantastic project. So the infographic, I know this is probably appearing a bit small on your screens, but the infographic really, I think, is a great representation of her thinking on palliative care and the structure of the study and what different parameters she was looking at. So this was a prospective cohort study of 150 households in Malawi. So that means everyone in this cohort had an advanced cancer diagnosis. And then from that black box on the left of the screen, you can see that this population, then we had those that received palliative care in green and those that did not receive palliative care. These households are followed for 6 months. And over those 6 months, Dr. Bates and her team looked at effectiveness of the palliative care, that's in the light green box. So well-being of the patient, reduced severe health-related suffering for patient and family, increased end-of-life quality. Then in pink, they looked at the health system costs, costs and utilization of services, and then optimized use of healthcare resources. Then in yellow, the societal costs, direct costs, indirect costs like travel, and then dissaving, selling major assets, not being able to afford school tuition. And so some characteristics of her population: the average age was young, 50 years. As far as disease severity, at 6 months, there's 59% of households, the patients were alive in 59% of households. In the total population, 64% experienced catastrophic costs at 6 months. And there was a difference between her two groups. Nearly 70% of households who did not receive palliative care had catastrophic costs versus 47% in households that did receive palliative care. Also, palliative care was associated with reduced dissavings. That's that sale of major assets. And then there was this signal or trend that was not statistically significant, but found that the total household costs for healthcare with palliative care was less than without palliative care. So really robust and important work from Dr. Bates. Next, we'll go to Ethiopia. And I have here is this split screen presenting two projects on the same continuum. So back in 2018, Dr. Yosef Mamo and Dr. Tigene Wandemamagegnu and Ephraim Abatoon and I set out with our colleagues to conduct a needs assessment of palliative care needs in 4 different patient populations in both Addis Ababa and in the west of the country in Jimma, Ethiopia. We were in a home hospice run by Hospice Ethiopia, a non-communicable disease clinic, an oncology clinic, and an HIV clinic. And what we wanted to know were what were pain levels, what was the access like to pain medications, what could we learn about dissavings or sale of assets in order to pay for care? We found that, especially in the oncology clinic, there were very high levels of pain. 90% of patients had either moderate or severe pain, and this was in a location with access to morphine. We also found, if you look at the pie chart below, that 25% were not prescribed any analgesia. And we found high costs of illness and really devastating stories of patients and families selling major assets like farmland, livestock, wedding gold, removing their children from school to pay for care that was frequently futile and without really knowledge of their diagnosis or prognosis. So based on that needs assessment, our next step was to conduct a feasibility study. So we went specifically to that oncology clinic, and we went back to the same clinic where there had been such high levels of pain and sale of major assets and low coverage with analgesics. And we said, all right, so now we are going to integrate early palliative care into patients in the cancer clinic. So these were newly diagnosed cancer patients, advanced disease, and we were going to integrate palliative care from the time of diagnosis. And then this was a feasibility study. We wanted to study, can we do this? Can we do this type of research in this location? What are the challenges? What would we need to change in order to do a bigger study in this location in order to get even more information? And then what signals do we find related to health economic outcomes like costs? And so we found a number of challenges, especially related to COVID and adaptations that we needed to make during the COVID-19 pandemic, and high loss to follow up. We had one unexpected finding, which was fantastic, in that palliative care is now more common and analgesics were more widely prescribed, which was quite a happy finding. We found that it was possible to integrate early palliative care into cancer care in this location, and that it could be delivered at low cost, just about $20 US for the duration of care per patient. And we also found that patients in the who had received palliative care had far lower costs than those who did not. So let me take a moment here and just summarize our take-home points. We've learned that palliative care is not the same as hospice care, that it's patient-centered, holistic, that it improves the quality of life and of death. We know that ideally it's begun at the time of diagnosis with an incurable disease, and it's integrated into regular medical care. We know that palliative care reduces financial impoverishment while aligning with patients' wishes, and likely offers cost savings, not just on the microeconomic or family level, but also on a health system level. The gaps are really to identify best practices for palliative care delivery in low and middle income countries, and in order to guide health decision makers in funding publicly accessible and widely available palliative care globally, and really that palliative care, we should all be arguing for palliative care as a poverty reduction strategy globally, especially for those with the greatest need, and that's in low and middle income countries. So on the horizon, we have the African Palliative Care Association conference is coming up in the end of August, and that is a hybrid, virtual and in person. The World Health Organization has assembled a group of thought leaders and experts in the health economics of palliative care, and together they are working on a technical brief that is expected by the end of 2022, and that should be really a very strong piece of work with a lot of a summary of sort of evidence on this, of in-depth evidence on this. And then, I think things to keep an eye out for are more health economic studies to identify these best practices in palliative care in low and middle income countries, as well as mHealth solutions. So using mobile health technology to address gaps both in training and education, as well as geographical gaps because of rural locations on the continent. If you're interested in learning more, these are a couple of resources. There's the Worldwide Hospice and Palliative Care Alliance, the International Hospice and Palliative Care Alliance, and then CUGH, the Consortium for Universities of Global Health, has a particular palliative care interest group. I'm on Twitter. Here's my handle. Please reach out and connect. And thank you very much. It's been a pleasure.